that. Okay, we have a few talks this morning. Let me see if I can make sure I get my talk ready. So I thought I would start off here talking about usual and unusual IOL problems. And these are my disclosures. I know there are a lot. I apologize. It's always fun to work with industry to try to improve our technology. So let's start with something that maybe isn't so unusual. It's not that common, mind you, but dealing with a toric lens that's resulted in residual cylinder. This patient here had a T5, put it almost 90 degrees, but post-operatively the patient has a diopter of cylinder left. We know, of course, that for every degree we're off approximately, we can lose about 3% of our correction. And so we have to, of course, be right on target. Now, what do we do in these situations here? Well, first of all, we want to check the axis, make sure the spherical equivalent is appropriate. If it isn't, we may need to think about either exchanging the lens or perhaps doing a laser vision correction. And I do then decide whether we will try to do a corneal treatment with LRIs or whether we will consider doing a toric rotation. I'm not a big proponent of LRIs, especially with toric lenses, but I do think there's a role for LRIs or corneal relaxing incisions post-operatively for a small refractive cylinder. Remember, we need to treat the refractive cylinder, not the corneal cylinder, first of all. And I have a general rule here about the 1-2-3 rule in terms of how much to correct. Now, there's very much an art to this. It's very much based on wound healing. So these are general approximations. And once we get over a diopter and a half, I think it becomes more difficult to control how much we treat. These are arcuate incisions made at the slit lamp. We don't need to have a femto laser to do corneal relaxing incisions. And you'll see I have some marks on the cornea where I placed my corneal incisions. These marks come from this specially designed marker. This is from Mastel, like I showed yesterday. And we have two rays where we line it up on the steep axis of the refractive cylinder, and each of these little teeth can give us a guidance how wide to make the arc. This would be 30 degrees. Between the second teeth, it'd be 45, and 60, 75, and 90. We can use metal blades, we can use diamond blades. I love diamond blades. This is a specially designed blade we have at the slit lamp with a foot plate on it. And here's what it looks like basically. We have the rotatable two-ray marker. I can rotate it to the axis of where I wish to place the arcuate incisions. I have the teeth identified here. At the slit lamp, we ask the patient to look straight ahead. Eyes open and push down. We push for about 3-4 seconds with no ink, and again, this is all we need to do to get a good mark on the cornea. There you see the marks on the cornea. So this patient has to have an arcuate probably around 80 degrees or so, and because the patient's sitting up, we don't need to worry about cyclotorsion. And then we can proceed with this speculum. There's the blade. We basically perform the arcuate incision at the slit lamp. It's pretty amazing what we do at the slit lamp. We inject in the eye, we suture on the eye, we make cuts on the eye like this, we remove foreign bodies, go into syncytialysis even. And so we do these arcs. This was about 45 degrees. And sometime we need to retreat. We can add more if we need to, but typically we go for about a diopter and a half, not much more than that. If they're more than that, and that's what it looks like at the end of the case, at the end of the procedure. It can be done, of course, in the OR or the minor room as well. If the lens is off by more than a diopter, you see this patient here has 2.25 diopters. This is the refraction, minus 1.25, plus 2.25 at 50 degrees. The toric lens is supposed to correct 2 diopters cylinder. And the website astigmatismfix.com or the Barrett RX formula can be very helpful to determine how much you need to rotate the lens. All we need to do is enter a few things. What toric lens did we use, and what's the refraction, and what degree the lens is at. And by doing this, it tells us, okay, let's rotate the lens from where it is right now, 155 degrees to 15 degrees. And if we proceed within the first month or so, we typically can do this without having to open up the capsular bag very much. Of course, why do lenses rotate? There's many reasons. One reason is because of retained viscoelastic. Here I've injected viscoelastic in the anterior chamber, but not into the capsular bag. The reason is because there's still, there's still a lot of room there. The fibrosis is still not wrapped around the haptics typically. And so we can now basically use a little forceps to hold the capsule and use a Sinskey hook to kind of free up the haptic here. Now, of course, there's no problem to inject viscoelastic if we have to, and be careful to remove it, of course. But you can see simply by just extracting the haptic from the angle, looking closely to make sure the bag is not moving or torquing, we can basically release it from the early epithelial scarring around the haptic. We have one free, the other free as well, and then we can rotate the lens here to 15 degrees based on the marks on the cornea, which is not easy for you to see here because the cornea is not dry. And I don't have to remove viscoelastic from the capsular bag. Oh, there's the marks here, right there on the cornea. And we can remove the viscoelastic from the anterior chamber easily, and we're done. So this is certainly one way to do it. And sometimes even at the slit lamp, on post-op day 1, you can actually use a little 30-gauge needle to do that, but that may be a little bit asking for too much unless the lens is way off. Another example, patient here has a residual cylinder of 2 diopters, 2.75 diopters. The lens is sitting at 150 degrees, but the ideal position should be 98. Now you may say, why not just put the lens back to where you put it originally, where it's supposed to be? Well, remember though, the refraction may have changed based on the surgically induced astigmatism, so always run some sort of refractive divergence formula or some sort of formula like this using the astigmatismfix.com to do that. We often do put a capsular tension ring in as well, because we feel the CTR may expand the capsular bag and may perhaps prevent rotation. Here again, and we could all do small incisions. This is a bit longer post-operatively, so we're going to use the Sinskey hook and a pair of micro forceps. The forceps hold the anterior capsule. It is rarely a difficult problem to lift off the capsule from the lens. Now here I'm injecting a little bit of viscoelastic just to kind of free up the haptic, both along the nasal and the temporal side. And again, as long as the capsular bag is not mobile, we can typically inject viscoelastic. And here we need to make sure we release the anterior and posterior leaflets. It obviously helps to have good capsule overlap over the optic. It helps us. Now here, what we're doing here now is injecting a CTR to put it into the bag. This may, again, help prevent rotation by expanding the capsule, reducing the anterior-posterior distance, and creating a better sandwich around the lens. We rotate the lens back in position, remove viscoelastic using the irrigation aspiration, and we completed the case, and the lens is sitting well. So we have a long series of this as well. Now I know there's many medical students here. You know, this was a case in the OR, and this is a medical student in the OR watching us do surgery. He got cut out. Okay, we did not accept him into ophthalmology. We said, okay, go to psychiatry or something, you know. Now this patient here, you can see, has a multifocal lens. The patient paid $2,000 for a multifocal lens. The surgeon broke the capsule, but the patient paid for it, so let's put it in. And unfortunately, the lens, of course, is subluxed. There's one haptic sitting behind the capsule, and the rest of the lens sitting in front of the capsule. It's not going to work, plus it's causing uveitis as well. But we do have a good anterior capsulotomy present. And as I said yesterday, we can place one-piece lenses in a reverse optic capture position, keeping the haptics behind the capsular bag, behind the anterior and posterior capsule. At this point in time, the anterior and posterior capsule has fused. So basically we have just one capsule shelf. And using, again, a pair of forceps, very helpful to have the right instruments here. We basically hold the optic in front of the capsular bag and place the remaining haptic behind. By putting a lens in reverse optic capture, we create a little bit of myopia because the lens is sitting a bit anterior, not as much of it was in the sulcus, anywhere from 0.3 to 0.5 diopters here, and you see the lens in the sulcus there as well. It's just a view in our operating room, place where we love to be. This patient here has an anterior chamber lens. Anterior chamber lenses are not bad, but they have to be well sized. And the problem is that, of course, sizing can become a problem. This is an oversized antechamber lens in a somewhat smaller anterior segment. And so you can see the synechiae formation and the pupil ovalization, uveitis. Here we're going to prepare the eye for intrascleral haptic fixation, or as some have called the glued IOL technique. Now we can use the Yamani technique as well. We put infusion, and the patient has vitrectomies. It's nice to have some infusion in the eye because the eye can become very soft during the manipulations. We're injecting some triamcinolone just to be sure there's no vitreous. We'll make our sclerotomy, making sure the sclerotomy, by the way, is not too anterior. Because if it's too anterior, it can result in pupil capture and chafing. So we want to make sure we identify not the limbus, but identify the blue zone and go posterior to the blue zone, about 1.5 millimeters from the blue zone. We can then do some vitrectomy as needed to make sure we've cleared the anterior segment of any vitreous. And we'll fast forward that. It's important for these scleral-fixated lenses to do that. Now, sometimes removing the ACIOL can be difficult. We have to sometimes cut the haptics, but when we're able to release the synechiae and the antechamber lens, we can then do a bit of cleanup. We do have to make a larger incision, of course, 6 millimeter incision to remove the lens. Move the lens nasally, pull it out from the temporal haptic, and then remove it here through the temporal incision. Again, infusion really helps us. And then now we can place a three-piece lens, typically a hydrophobic three-piece lens with PMA haptics, using the well-described micrograsper to grab the tip of the haptic and pull it out. Now, we could, of course, maybe gone on and put another antechamber lens or an iris-fixated lens or a sclerosuture lens. The cornea wasn't in the best shape, so I felt it'd be better to use this technique. And here we're basically, again, extracting the haptic out. And a very clever technique described by Gabor Shorioth originally. Amar Agarwal has popularized it, and now Yamani has now developed some further innovations here. We then basically make a small tunnel with a 26 gauge needle. And these have been actually quite, reasonably positioned in our experience. The haptic sometimes can get twisted. You have to be careful not to pull the haptic and twist it too much, otherwise we get a bend and get some tilt on the lens. And we now have the lens positioned there as well. And then we can basically continue with some glue just to help the scleral to be closed, and the conjunctiva as well. The glue does not hold the lens in place. It's the scleral tunnel that does. This is just another view in our operating room. I love screens. It's like information overload in our operating room. So we have multiple screens and 3D screens, everything else going on here as well. Anyone know what's going on here? This is calcification from a hydrophilic lens. This is the HD analyzer. It's a double pass technology looking at ocular scatter. This is the right eye, minimal scatter. The left eye, you can see the calcification cause intense scatter. Lots of glare and big problems here. And this is a modified plate lens done many years ago, and the patients had a capsulotomy done. You can see some som rings present. The goal here is to remove at least the optic and place a three-piece lens in the sulcus, maybe with optic capture. Again, even though it's 10 years later, we can typically lift off the IOL from the capsule itself using manual micrograspers and a Sinskey hook. And then we can inject viscoelastic here. Now, it's not always easy to look at the haptic here. It's encased within fibrotic tissue. So we're going to cut the haptics from the optic on this side. And we can always leave that as well. Cut, again, further cutting of haptics, we were able to at least extract one haptic on this side. And then we can then cut the lens in half and remove it. You can see the calcification within the actual lens itself, and then I'm actually able to carefully dissect. Now I could have left it in there. I'm a bit obsessive again. We could leave it in there, and then we can basically remove that remaining haptic, as you see there. Place the three-piece lens into the sulcus, and then optic capture the lens in place. So that's basically a scenario there. For the last minute or so, I want to just show you why it's not a good idea to run overtime. I'm kidding. It's not a good idea to place two lenses in a small eye. This is a 17 millimeter eye with two lenses. Not a good idea. These patients have angle closure, synechial formation, interlenticular opacification. We have to go and remove both lenses from the eye and put a high power lens in the capsular bag there for this situation as well. And I think that's very important to remember the concerns around two lenses as well in the small. In the regular eye, though, it's fine. So those are some unusual IOL problems I want to share with you here today, and I'll let our next speaker, I think it's Snyder? So it's kind of like Mike and Ike, but a little bit of a different kind of Mike and Ike. So where's Snyder? There's Snyder. Get him up here.
Alrighty, so we go from some really cool implant lenses cases to some refractive surprises, which in a way are also implant lens related. I do want to acknowledge my disclosures, and for this one there are a couple that are relevant. So I'm just going to start off by a little prologue and think about troubleshooting. This is a recent case sent to me by a colleague. And the email came, it says, so far I have 3 patients with refractive surprises after Symphony lens. None are laser vision correction patients. Range is -1.25 to -2-ish. Looked at all of the things, not sure what's going on. Anybody notice anything different? I responded, have not, put in hundreds, but very easy to over-minus refractions on these lenses. Need to push the plus. Response, did it myself. Refraction is stable, pretty far out. So, well, how many have you noticed with this? Well, is there any topography problems? What are you using for your calculation methods? Well, I've noticed 3 out of 150 cases. That's not bad. Optimized with Xiidra and Restasis, surface is okay. I primarily use SRKT. SRKT. Really? Let me digress. I love my team. These are the testing technicians at Cincinnati Eye Institute. They're superb. It's Joyce, Michelle, Lisa, Dina, Mary. Pay special attention to Mary for a moment, will you? Let me digress again. When we use IOL calculations, we want modern day accuracy, and we need this Millennium formula. That means the Hill RBF, the Barrett, the Olson. The SRKT came out in 1990. That's 28 years ago. Haggis, 1993. Holiday 2, 1998. Remember Mary? This was Mary when the Haggis formula came out. Okay? So we looked at a prospective study with the Hill RBF initial database, and we had 3 study sites. One was Dr. Hill's site, one was Dr. Scoper's site in Norfolk, Virginia, and Cincinnati Eye Institute. So study criteria, we looked at patients who were having elective cataract surgery. They had to have good visual potential, no amblyopia. They had to have good retinas, good corneas. And they had to have only regular astigmatism. They had to meet the LensStar criteria because the formula was validated on the LensStar, and it met all of those criteria for each case. They could not have had prior refractive surgery, and we used only the SN681 or the SN60WF because they have similar asphericity and A constant. So that's how we started things out. They always had to be in bounds. That's an interesting thing about the RBF, is it tells you whether it's in bounds or out of bounds, and we'll talk about that later. Out of bounds means that the data set doesn't know how to recognize that particular data point. We aimed for near plano in all of these cases in the study. And they had to have in-the-bag placement with a capsulorhexis covering the optic edge for 360 degrees. We had to have at least 1 month of follow-up and a reliable refractive endpoint. The range of values was pretty broad. We had 467 patients, ranges from +7 to 30 diopter implants. We had small eyes, we had longer eyes, we had short anterior chambers, we had longer anterior chambers, we had flat Ks, we had steep Ks, we had it all. And we were looking at half a diopter of accuracy. Yes, that's right, half diopter of accuracy. And in the axial myopes, we hit 98.4% within that half target. Not bad. No, we didn't have any zero power implants because I know you guys are thinking a zero power implant, it doesn't matter where you put it. These are only available from 7.5 to 30. So normal axial lengths, we hit 92% of people within a half a diopter. And even in the axial hyperopes, these are the toughest dyes, we actually hit 84% within a half diopter. And this is a particularly tough group because their anterior chamber depths are different, and the traditional go-to formulas for hyperopes, well, let's compare. The RBF on the left, Holiday 2, and Hoffer Q. Did a little bit better with the Barrett and Olson, but the RBF still really prevailed, and this was on the first data set. So please use an up-to-date method for your calculations. And since the RBF calculator uses big data, the more data it gets, the more accurate the outcomes will be, and this is constantly being updated. There's going to be a new update of the calculator out this autumn on tens of thousands of data points. These are all free to access. You can get it on www.rbfcalculator.com, and the Barrett Universal 2 is also available free on the internet. So let's jump into our surprises. Surprise number 1. 62-year-old lady undergoes uneventful cataract surgery with a distant aim at 1 day, count fingers vision. She says, boy, I see great out of my old glasses. Ooh, we refracted her, minus 5.5 diopters for 2020. Ooh, not good. Calculation sheets and OR notes were confirmed, and the proper IOL was selected for the Plano result. Biometry was repeated, and we found the axial length was 80 microns less. Well, 80 microns isn't that much. The keratometry, however, was 5.5 diopters steeper than the original measurement. Anybody want to guess what happened here? Go ahead and shout it out, don't be shy. What happened? First set of measurements were done with her contact lens on, and we measured the front surface of her contact lens. Ooh, bad. This is about 17 years ago, so don't do that. It's really embarrassing. By the way, anybody want to know how thick a contact lens average is? Yeah, 80 microns. Surprise number 2. 69-year-old woman underwent uneventful cataract surgery with a Collamer plate haptic PCIOL placed in the capsular bag. The post-op refractions, day 1, 2020. Month 1, 125, improving to 2020 with a roughly +2 hyperopic refraction. Not good. What happened with this patient is the capsular bag contracted a little bit. The implant lens actually migrated posterior and the bag curled. Note here, the slit beam first hits the anterior edge of the iris, then it hits the capsulorhexis, then it hits the anterior IOL surface and the posterior IOL surface. This lens is vaulted backwards and had a progressive hyperopic shift which continued over time. Patient had an IOL exchange for the same powered 3-piece acrylic implant lens 2020 planosphere result. By the way, there was no pseudoexfoliation syndrome, no zonular abnormalities were noted in this eye or the fellow eye. Be very cautious using super soft lenses. So the soft profile lenses really do not have a robust enough haptic. If you have to use a really soft lens for whatever reason, use a capsular tension ring, especially if it's a plate lens. The softer lenses are the Collamer lenses, some of the hydrophilic acrylic lenses, and the planar open loop lenses may be of lesser risk since they don't have the same tendency to vault. Surprise 3. 60-year-old woman underwent uncomplicated cataract surgery with a multifocal IOL. 3 new generation formulas agreed on the IOL power, which was an SN6AD1 27.0, and it was implanted accurately. Her post-op refraction after stabilization was -2.25 for 2020. An IOL exchange was performed for an SN6AD1 23.5 diopter lens with 3.5 diopters less power to accommodate for the -2.25 external refractive error which we found. And then the postoperative refraction stabilized at +150. So what happened? What are the possibilities here? Well, IOL number 1 could have been mislabeled, and the IOL power was accurately predicted the first time. Possibility number 2, IOL 2 was mislabeled, and the patient had a formula failure the first time. All 3 formulas could have been wrong, and the second implant was mislabeled. Possibility number 3, they were both mislabeled. Possibility 4, both mislabeled and the formulas were all wrong. Or the laws of physics do not apply. So what now? What do we do? Do we exchange the implant lens again? Well, knowing that one of them had to be wrong, which one do we presume is right? What do we exchange for? Do we do hyperopic laser vision correction? Do we tell the patient, wear a contact lens, do a spectacle lens? The patient wants an IOL exchange. Are you willing to do it? What IOL power would you put in if you do it? Well, the resolution was, first, we took the IOL exchange off the table. I said, you can't do that. I'm going to quote my good friend Warren Hill. He says, sometimes someone needs to be the adult in the room and just say no. This was one of those instances. Surprise number 4. 64-year-old woman, unilaterally cataractus presbyope, undergoes cataract surgery elsewhere with a distance aim. Ends up with a -2 sphere result, which she decides to live with. 1 year later, referred for angle closure attack. Her exam shows a sulcus-placed PCIOL sealing the capsulorhexis with an intact capsular bag that has significant capsular bag distension. An attack of pseudophakic angle closure glaucoma was temporized with an iridotomy, and there was low broad PAS on gonioscopy. Here's the implant lens, and here's the biometry calculations. You see, they actually match up pretty darn well. I know you're going to pick on me here. You're going to say, Snyder, how come you have the SRKT calculations up there? You just told us it's from 28 plus years ago. As it turns out, all of the other formulas that we use require an accurate anterior chamber depth, which is very difficult to get when you have a distended capsular bag and a pseudofake. So we went with what we could use. So what now? What IOL power should we use? What IOL style should we use? Well, let's run into the case. So you can see we've got a nice clean bag. The capsulorhexis is intact. We're releasing some fluid from behind the implant, and we're going to pedunculate and cut the implant with IOL cutting scissors. These are made by Duckworth and Kent. I like to cut the acrylic implant lenses in 3, then they come out through a 2.2 millimeter wound a little bit nicer. We remove those pieces. I always like to place a capsular tension ring if I'm opening up a capsular bag for the second time. You have no idea what zonules are present, so if I have to reopen the bag anyway, it's nice to put in a capsular tension ring. I'm a big fan of placing the capsular tension rings manually. I find it much more straightforward, and you can feel resistance if it starts to catch up on the equator. So we place the capsular tension ring in. In this instance, we chose to just place the appropriate powered implant lens within the capsular bag. We ended up choosing a multifocal implant lens. We did a little bit of goniosynechiolisis, which you've seen Ike present yesterday. We aligned the Purkinje 1, 3, and 4 images to make sure that we're well centered. And at the end of the day, the patient had a very happy outcome with 20/20 uncorrected distance vision and J1 plus uncorrected. And the entire problem here was strictly that it was a capsular bag distension. Surprise number 5. 75-year-old lady underwent routine cataract surgery in the right eye. Post-op refraction -3.25 +1 at 177 for 2025. The fellow eye had a significant hyperopic refractive error, profound glare and blur. You can see why there's this big crack in the implant lens. The existing IOL was a ZC-BU 20.5 diopter lens. Here's the calculations. Ooh, there's a big difference. So this was a probably transcriptional error, and transcriptional errors do occur. That's what we're presuming. The case was done from the outside. We exchanged for a ZXT 150 16.0 diopter lens based on the biometry and repeat calculations. And how do we do the repeat calculations? Well, we confirmed it both from the biometry and the formulas, but also we know that a 20.5 diopter lens yielded the result that it did, and we ended up with, and there's the 2 to 3 rule. So we used the refractive error, plugged it back in backwards, ended up 20/20 +2 with a J3 result, and a very happy patient. So that was a case in which the initial procedure, there was some sort of a transcriptional error that occurred when somebody was looking at the calculation formulas. Everybody here use electronic records? We're forced to. It's awful, because it's very easy for different pages to open or refresh more slowly than you think they are, and it's potentially possible to be looking at the wrong page. Always look at the patient's name on every chart. Surprise number 6, and I think that'll be our last one for this. We have a routine phaco right eye, 17 diopter lens, predicted accurately. There's the topography and the biometry. Post-op day 1, uncorrected 20/50. Post-op week 1, uncorrected 20/50 with a bunch of residual astigmatism and a mild myopic shift. Post-op month 1, growing myopia, stable astigmatic outcome. So how are we going to pick the other lens for the other eye? This must be a formula failure, right? This must be somebody who just doesn't do that well. So we figured it's a formula failure. And when there's a formula failure, I usually like to presume that whatever would have worked properly for the first eye, I make that adjustment for the second eye. So if they ended up a refractive error, which was in this case roughly about minus 1.5 in the myopic direction, I just take off a little bit of power from the implant lens for the other eye. We undercorrected for the astigmatic component, so we'll overcorrect for the other eye. We went ahead and did the other eye, and the prediction was for an 18 diopter to 18.5 diopter lens. We went with a 15, so I was courageous. Happily, we ended up post-op day 1, 2020, uncorrected. Here's the funny part, though. Now we've got a cataract surgery in the left eye where we went 3 diopters less hyperopic than we should have, and we hit target, and we stayed stable for weeks and months. But the first eye is still a problem. At 2 months, the patient actually ended up doing better. Now she's only got a minus 0.75 refractive error. Isn't that odd? And by month 4, that was stable with 2015 result. We did an LRI at the slit lamp. I'll do LRIs for up to 2 diopters at the slit lamp. And we ended up with a very nice outcome. And at post-op month 5, the patient was uncorrected 20/20 J1+. Remember, this is the same implant lens. Very odd. The left eye still remains 20/20 uncorrected at 4 months out. So the interesting thing about this case, I don't have the right answer, but I picked the left eye implant lens based on the right eye outcome, and subsequently found that the right eye outcome that I based it on was wrong. But both of them stayed normal. I have no explanation other than suspension of the laws of physics to understand that. And the reason that I present this case is not all cases have an easy answer. And sometimes we can't find out what that answer is. But it's an interesting one nonetheless. And I'd like to thank you for letting me give this talk, and I think I'm going to turn things back over to Ike.
Thank you. Well, it's always good when Michael Snyder doesn't know an answer. I feel better. I feel a lot better, Michael. Okay, well, I think the next 2 talks, myself and Michael are going to speak about dealing with iris abnormalities and iris defects and iris issues. You know, as I think I may have alluded to the other day, these not only, of course, have visual functional issues, but they have real cosmesis and aesthetic concerns for our patients. You know, looking at someone in the eye, their self-esteem. There's a lot that we need to think about. Not to be vain, but really this is real, real life, human life. And so the most we can do to help these patients really is beyond just the vision and the function. And I have to say, I think over the years, I think I've seen us as ophthalmologists think about these more from a patient perspective rather than, listen, let's just get the vision to 20/20 or whatever we can get and we get out of there. I think there's a lot more to that. Photophobia also, of course, remains an issue. So how do we repair these? I'm going to focus probably a bit more on the manipulation of existing iris tissue, which I really prefer. We showed some cases yesterday, and I think today we'll show some cases as well on iris implants. I'm sure Michael will show that as well. He's the guru in these areas as well. And these are my disclosures. So what do we need to do this? Well, we don't need a lot. Actually, I truly think this is something that actually many cataract surgeons can tackle, especially a simple iris defect to close. I still like the tried and tested CIF4 needle on a 10-0 proline. I think the larger bore sutures tend to create more suture holes and cheese wiring. So this is what we typically use. This can degrade, of course, but over our experience has been actually quite good. A couple hooks, always a good idea, some Sinskey hooks and some Kugeln hooks. And I think that what has really transferred our abilities has been the use of microinstrumentation and using microinstruments that allow us to manipulate tissue in the eye, suture in the eye. When I started practice, I didn't see anybody, I saw people repairing irises with hooks and blunt instrumentation. I think the advent of anterior segment microinstrumentation like these, I think, have really allowed us to do much more in the eye than we thought, and not just borrow instruments from the VR surgeons. 23 or 25 gauge forceps can be used, and then there are a variety of ways to tie sutures, and I recommend just kind of getting comfortable with different techniques. Of course, the classic mechanical is always a good place to start, probably the easiest to conceptualize, because all the tying and the cinching down and the cutting of the suture is done outside the eye. You pull the knot to the wound. But this distorts tissue a lot. So others like Siepser and Ogawa and ourselves have kind of modified things. And this is a technique that one of my fellows has kind of called Ahmed. Basically, you'll see it's pretty simple. We pass the needle through the iris defect area. Notice that the paracentesis is made away from the area. We don't want to make it here. We want to make sure we can pass the needle nicely, a nice gentle pass. We then come out assisted with a docking cannula to avoid trapping the needle in the cornea. Then take a Kugeln hook and pull both of the ends out to the main incision. The incision should be about 1.5 millimeters or so, 2 millimeters. Now we have two free ends. Use a regular tying forceps and a micro tire. The micro tire is specially designed with smooth tip platforms. Twirl around the micro tire and grab the short end. Remember, there's a long end and a short end, like we're suturing outside the eye. And then grab it and slide it in. That's all it is. I really think this is something that I think is very manageable for most surgeons. And then we can basically cinch it down and cut it. This was a patient referred to me, a 34-year-old patient who had previous trabeculectomy with a remaining atonic pupil, pseudophakic, very bothered by the appearance and by the photophobia. This is a right and left eye here. There's her bleb. I want to try to, of course, avoid manipulating the bleb. And it's amazing, even after many years later, the iris, as long as there's no synechia or atrophy, can be quite readily manipulated. It's quite elastic and spongy. And of course, there is some risk of iridodylisis and bleeding, but it's actually quite uncommon in our hands. Notice, by the way, that this requires bimanual use of instrumentation. Notice, again, we're using not only our needle, but the micro forceps is being used to bring the iris to the needle. Take advantage of a second instrument in the eye to help manipulate tissue. I often see surgeons kind of pass needles without holding tissue. Imagine suturing sclera potentially without holding sclera, although you can do it without holding all the time, but it's nice to be able to do it for the first pass at least. And then come out again with a docking approach. Now here you see, again, our Ahmed approach. Bring the Kugeln out of the eye, loop around the micro tire, grab the short end. You can square the knot here, and then slide the knot into the eye to cinch it down, and watch the iris come together, controlled. One forceps outside the eye. And we do a slow pull here, and now we can bring the short end out of the eye again, lock the suture with a micro tire, and then slide in again. We have a lot of these videos on my YouTube channel and on YouTube. Others have published different ways and different techniques, but this is to me, after training residents and fellows over many years, training with other techniques, this truly, in my opinion, and then using a micro scissor to cut rather than a big scissor, is helpful. Now notice what I'm doing here. I'm taking 3 bites. This is kind of a partial cerclage, so to speak. By taking an extra third bite, it helps to round out the suture. I couldn't do it here up top because of the iridectomy, but it creates a rounder appearance of the pupil by taking that extra bite in the middle. And then we do the same thing, both ends out of the eye, loop the suture, slide it in. Okay, so you're getting the hang of it now. And you see the pupil is becoming rounder. We'll basically do another pass here, closing the pupil there, one more pass there. Again, both ends out of the eye, loop around with the micro tire and slide it in. Typically a 3-1-1 knot is used at the cut. And there's the appearance post-op. You can see the pre and post-op appearance as well. Now we can use the same micro tires to also suture in the eye or tie in the eye. And this again requires us to use the anterior chamber as a closed system, and remember to use the incisions as a fulcrum. This is a phakic patient. Remember I said yesterday I do a lot of phakic iris repairs. Young 20-some-year-old who has a knife injury in the eye, but good vision and good accommodation. I didn't want to remove the lens if I didn't have to. So this scholastic under the iris here is being used, and then we will pass the needle through the eye. Notice again my microforcep holding the iris. This does require a little bit of an eye for the art of the iris and the pupil. Approximating where the suture should be. You can use 2 micro instruments to bring the iris together as well to help to approximate where it goes. We're passing it all through the eye, through that small incision, and now we have a long end here below, and we have a short end here. Cut the short end. Now I'm just going to show using 2 micro tires to twirl the long end along the micro tire, grab the short end, and then cinch it down to bring the iris defect closed. And that basically is using micro instrumentation to do this by bringing the iris together. And then we can then lock the suture by again taking that long suture on the left side of the field here, doing a backhanded loop to again lock it and grab the short end and pull. Remember, we have to keep the idea of the incisions as a fulcrum, avoid tension and torquing of the wound, and we can then lock that suture. So I'll just forward this here just to show again, and we have to often place multiple sutures to do that, and be obsessive a bit. I didn't like the notch there, so I put an extra suture in there. Didn't need cautery here, but sometimes we do use cautery as we showed. And there's the pre-op, there's a post-op. This is immediately post-op. This is a few weeks later. You can see his appearance. So, you know, he got a job, he's making some money, you know, he's happy, he's got a girlfriend, very nice. I met her, she's very nice. So he's happy now. We changed his life. We literally changed his life, you know. This is a patient maybe that we may have chosen to do an iris prosthesis, but it's amazing how often we can manipulate the iris. This patient had previous surgery, had a large iridectomy performed many years later. The surgery was performed many years earlier, I should say. And again, we basically place our sutures out. It's helpful, again, to be able to use our left and right hand. If you're very right hand dominant, you can move the chair around or change your trajectory of your needle pass. We'll then place that suture and tie the suture there to bring the iris together. But of course, the pupil is quite correctopic at this point. And so again, here we're bringing out our 23 gauge pencil tip cautery. This is basically again manipulating the iris tissue here. You know, this is a very straightforward technique. I had a case where we had an iris bleeder. I thought, well, okay, let me cauterize that. This cautery device is what I use for my sclera, and then lo and behold, we realized, hey, we can actually manipulate the iris. Just like we use post-operative argon laser or 532 to do the same thing as well. Remember, it's a bipolar cautery attached to our phaco machine. And then you'll see we'll continue to bring that pupil together. It's very important to get the pupil round. I think that's a really important thing for our patients to do that. You can see there's a little bit of a straight edge there. I'll place another bite there. It's okay to leave a little tiny area in the periphery there, kind of like an iridectomy, so to speak. And again, using the iris cautery really helps us to kind of do a little bit of extra reshaping here of the pupil there. There's some pigmentary changes that occur, and we have these cases now 7-8 years post-op, and the pupil remains quite good there. This was a patient here who came to me from out of the country, myopic patient with an atonic dilated pupil with a cataract. She loved her multifocal contacts. And I'm not a big, eager multifocal IOL surgeon, I'll be honest with you, but she convinced me to say, hey, listen, I really want a multifocal lens. I was worried, of course, because I'm going to suture her pupil down. I'm worried, of course, if she's unhappy, I'm going to have to undo all my work. But the good news is she won't have a large pupil, which can impact at least some multifocal lenses. So we'll basically place the CTR in. Here's a diffractive pupil-independent multifocal toric. placed into the capsular bag, remove the OVD, center the lens on the first Purkinje image, and carry on. Here we're going to use a pupillary cerclage technique to do a purse string suture. Again, a double-armed CIF4 10-proline suture. The work you see is done not by the needle, but by the forceps. And the forceps are really what really makes a difference as far as controlling the iris tissue. You can do about a quarter of the pupil, or about a third at one time, come out here through a paracentesis, and then go back in the eye again to continue along here. I like starting nasally and come toward my temporal incision, and then I can tie through my temporal incision. And notice basically it's like a baseball stitch, kind of going from over and under. The closer the bites, the more round the pupil can be, and continue on. I do get asked what anesthesia do we use. Most of the time is topical. Often I forget to inject some intracameral lidocaine, but that's also helpful, I guess. Of course, you can block the patient as well if the patient is moving around, because you want to have good control to do this. We then come out through the main incision here, and then again I'm using the Ahmed technique, tying outside the eye and sliding it in. This gives us good control to make sure the pupil is properly, adequately sized, because after all this work, we don't want to tie it too tight. A mechanical technique would bring the pupil all the way to the incision to tie it. A Seepster slide knot works very well as well, of course. And here we can basically get the pupil down to a reasonable size. I like to try to, get close to what we are in the fellow eye, not smaller than 3.5 millimeters, but about that size to match the fellow eye. Again, we realize the pupil will not dilate in dark or pharmacologically. And this is basically her appearance here post-operatively. She was quite pleased with that result. And sometimes we have to do some pretty big manipulations. This patient actually, I know the shields, this patient actually had iris tumor treatment by actually Jerry and Carol Shields. I know they had to leave, but this was a patient that was sent up to us, and a young patient here. And we're going to do a lot of manipulation to try to get, and I know this patient's phakic, so yes, probably cataract in the future, but still a good accommodation, good vision. Some cautery. I'm just going to fast forward again. Multiple passes here to bring the temporal iris together, releasing the synechia from the cornea without causing a decimate detachment. Suturing the defect again, multiple passes, suturing in the eye as I showed earlier. And then using more cautery to get the pupil arranged, a little bit of vitrectomy actually to kind of remove some of the iris here. And there we have the end of the case. We have a pupil that's reasonably centered as well. So those are some cases of manipulating the iris, suturing, cauterizing, manipulating, stretching, all great techniques. Of course, iris prostheses have an important role as well. I hope Michael will talk about that. I'm sure he will. He spoke about it before, and he's the original iris prosthesis guy. And it's really rewarding to help these patients. They feel very satisfied. They're really uplifted as a wholesome treatment here in helping our patients with multiple comorbidities. Thank you very much.
Very nice.
My disclosures haven't changed since earlier. And a couple things. The first one's actually not true anymore. Iris prostheses were previously not FDA approved, but we got an approval last month. Yes, finally there is something approved, and same other things that we've talked about before. Why should we care about the iris? Ike touched on this earlier. Why should we care? What's important about it? Why should we pay any attention at all? Anybody ever have a case of IFIS, floppy iris syndrome? Yeah, okay. All of us who operate on cataracts, we're going to see that. This was a routine cataract in an IFIS patient. And as you might imagine, the patient wasn't so happy afterwards. Patient had light sensitivity and glare. Not so surprising, a lot more light is getting in than it should. Normally, we just have light coming in through the pupil, a lot of excess light, but we all know about that. One of the things that we don't talk about much is the focused versus defocused light, and this is a very important point. Only the light that goes through the implant lens is focused. The other light that's going around the implant lens is defocused. This is what that looks like to a patient. Have you ever been in a movie theater and there's a particularly tense point in the film? The music is getting a little bit deeper, dun, 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 and then some jerk opens the door to the theater, and the light comes in and it hits the screen, and the viewing experience is diminished. Well, the projector is still hitting the screen with the same number of lumens, and the projector is still in focus, but our viewing experience is diminished because of the defocused light. That's what some of these iris patients are dealing with all day long. Are 3 images better than 1? I think not. This IFIS patient had monocular triplopia. 1 image through the pupil, 1 image through the peripheral implant lens, and a shadowed image from outside the implant lens. Not a great situation. And of course, we all know about edge glare, and we talk about that a lot. So we're going to talk about different approaches to iris management. I'm going to skip most of the suturing because Ike's done a really good job talking about that. But if we think about it, there's 3 ways we can have a problem with the iris. Either we have too much iris, we have not enough iris, or we have iris in the wrong place. So this is a case of too much iris. This 2-year-old child had dense amblyopia because of a very prominent persistent pupillary membrane. So we took the patient to the operating room. We put a little bit of OVD in the anterior chamber. We put a little bit of OVD underneath the pupillary membrane. And we used this wonderful device, which I like to call a scissors. And we just gently trimmed the attachments of this pupillary membrane to the native iris. We're not removing normal stroma. We're not removing any sphincter muscle. The patient has been given midriatic drops already. This is all just cutting the attachments of the pupillary membrane. Now you can do this with either a reusable or a disposable scissors. The vitreoretinal scissors work really nice for this. You can actually bend them up to 90 degrees in a gentle curve for anterior segment use if the ergonomics work better that way. And you can see that just by severing these attachments of the pupillary membrane and removing the pupillary membrane itself, we were able to create a normal aperture, and the child ended up having some progress with the amblyopia therapy, and the pupillary membrane just comes out the paracentesis. Iris cautery is a wonderful technique. Ike has showed this really well, so I'm not going to spend any time duplicating that. Vitractor trimming, he briefly touched upon, but it's really important. Small gauge vitractor, this is a 27. This is a complex eye done in combination with my vitreoretinal colleagues, and we're just reshaping the iris using this 27 gauge cutter, and it's very seductive. It's almost like using the eraser tool on the painting programs on our computers, but do keep in mind that there is no Control Z button, so don't remove too much, okay? But it's a wonderful technique, and you can see that as we shape this along, we can get a very refined outcome, and it can get pretty darn close to round, and as Ike said, it does make a difference, and I think it's an impact for these patients. Obviously, this is not enough iris to work with to make it look pretty again. This patient had the iris caught on an eye stent in the attempt of placing it after the routine cataract surgery. So the patient's vision is limited by blood which was trapped within the capsular bag. This is another great use of the vitractor. The retina surgeons always tell me that there's nothing that the vitractor loves more than iris except retina. And so here we are just using the vitractor to remove this necrotic subtotal iridodialysis, and it's really kind of fun actually. It's kind of like a Pac-Man game on the computer. But we want to make sure to trim enough so that it's not going to eventually flop into the angle. And then we reopen the capsular bag the same way that we would if we were doing an implant lens exchange. But in this case, we're not going to remove the implant lens. We're just going to reopen the bag so that we can evacuate some of that blood. We're going to place a capsular tension ring because we don't know how the zonules may be in the long haul. Now we're going to measure the capsular bag. We're measuring it with an intraocular ruler. MST makes this instrument. And we're actually sizing it for a custom iris prosthesis made based on a picture of the fellow eye. We're trimming it to the size of the capsular bag. The outer part we give as a little souvenir to the patient. The inner part is what we implant. We're going to fold this in a trifold fashion with the colored side outward. Always important to have the colored side outward. And then we're going to place it into an implant lens injection cartridge. In this instance, this is an off-label use of the Johnson & Johnson Vision Silver Series injection cartridge, and we kind of tuck it up into the barrel of the cartridge. It's a little bit awkward, but it works pretty nicely. We use a cohesive viscoelastic for this, and then we're going to inject the implant into the capsular bag underneath that capsulorhexis margin. You can see the capsulorhexis margin in this case since it's fairly fibrotic. In a case that's not done at the time of cataract surgery and not later, we will use trypan blue to stain the capsule so we can see it a little bit better. We tuck the device under the capsule margin, and then we unfold it and place the trailing portion underneath the capsule margin. We tuck it and unfold it into its planar configuration. And remember the eye stent that they weren't able to get in the first time? Well, we put that in while we were in the neighborhood as well. Ike always gets excited when I place a glaucoma stent. It's always very fun for him. And we can see that it really blocks a lot of the light. This is the post-op slit lamp appearance. On retroillumination, you can actually see the ciliary processes around the outside of the capsular bag, and a really very happy outcome from what was an unhappy routine cataract surgery. So the FDA has now given us approval to use these devices in the U.S. You guys, of course, have had access forever. This is a congenital aniridic case. You're looking at the white lens in a very, very shallow anterior chamber, and you've seen cases like this. So I'm going to skip the case and just show you the outcome. Looks pretty darn good. We've actually had some of these patients where the patients have gone to an urgent care and they've said they wanted to dilate the pupil. Said, no, you can't do that. It's plastic. No, let's try anyway. Right? They didn't believe them. In albinotic patients, this is a really great instance for this. Here's an albino patient prior to cataract surgery. Here's the albino patient after cataract surgery with an iris prosthesis placed in the capsular bag. In this instance, just a black device. And that's what they look like at the slit lamp afterwards. They actually look Paul Newman blue. They're usually pretty darn happy with how they look as well. But do keep in mind that in albino patients, it will not eliminate their light sensitivity. They also have no pigment in their choroid and no pigment in their RPE, so there's stray light that actually enters the eye through the scleral wall, so they will still have some residual issues with that. This is a case that I like to call the tale of the mermaid's tail. A young woman was sleeping one night, there was a storm, and that mermaid fell on her eye while she was sleeping. It created that appearance, and here's what she looked like. Count fingers, aphakic 20/40, but a moderate left exotropia with diplopia. You can see there's a pretty irregular but very high astigmatism, but we figured, well, maybe we can get rid of some of it. She really didn't want to have a corneal transplant. So we did supramaximal limbal relaxing incisions. We tried to clean off some of this Salzmanoid stuff that was emanating from her scar. I like to use a technique using 4-point fixation, and we placed a sutured PCIOL in. We measured the ciliary sulcus, and this same device that you saw before, we're now going to place into the ciliary sulcus. We're going to use 2 horizontal mattress sutures. And then using the same openings that we used for suturing the posterior chamber implant lens, we're going to retrieve each of the corresponding sutures from the corresponding spots. And really the hardest part of this is keeping track of all of the spaghetti, right? We just need to make sure that the right suture ends up in the right hole. And it's very easy to get that confused. Ask me how I know, right? And so we're just going to take up the slack of the sutures. We tighten them up. We make sure to protect the implant lens from contacting the cornea at any time as we're unfolding the device. And we put just enough suture tension to center the implant lens and the artificial iris device. Here's what the patient looked post-operatively at the end of the case. And she was actually really very happy with the outcome. I think we have a post-operative slide on here too. Here's what she looks like afterwards. 20/20 uncorrected. Boy, sometimes you just get lucky. The orthophoria was also just lucky because she was diplopic with a contact lens. You know, sometimes the bread just lands butter up, right? So that was a kind of fun one. So the things that are important in this case for me are that you can multiply fixate all kinds of devices to make them secure. There's no rule that you can only fixate one implant in each eye. And IOLs do not behave the same as contact lenses. Even people who are diplopic with a contact lens sometimes will get enough good vision that their diplopia goes away with a good implant. High astigmatism can be tweaked to surprisingly good amounts in traumatic cases. But you might say, what about the view of the retina? Is that an issue? I know there's a bunch of retina surgeons here, and they're probably saying, boy, I don't know, how am I going to dilate that pupil? It's made of plastic, right? So we need to keep in mind, though, that while the device's central aperture is 3.35 millimeters, that's the real pupil. The entrance pupil is what we all think about as the pupil, but that's magnified by the cornea. So a 3.35 millimeter machined pupil really correlates to more about 4.25 to 4.5 of what we think about as a pupil size, and that's usually pretty darn good. In fact, we've reported a retrospective study, Dr. Toygar, myself, and Dr. Riemann, with 20 vitreoretinal procedures through these devices, 8 different surgeons at 5 different academic institutions. Some were academic, some were private, 3 different operative microscopes, 2 different wide-angle viewing systems. What we found that in no case was the vitreoretinal surgery impeded by the device. One surgeon indicated that it was a little tough to see the periphery under air. Okay, I'll grant you that. Remember that first case I showed you at the very beginning? The IFAS patient? Here's what they looked like afterwards. Very happy. Need to place a capsular tension ring anytime these devices go into the capsular bag. The pictures above are ones of what it looks like when you don't place a capsular tension ring in the capsular bag with them. So always requires a capsular tension ring. Here's a patient that had medication-related iris atrophy, worse in the left eye than the right. In the left eye, there was a bunch of pigment loss. In the right, the sphincter was bad, but that's all. We put a cerclage suture on the right eye. We put a device in the left eye, and here's the 2 eyes next to each other. Very happy patient, very happy result. Do not confuse these devices. Do not confuse these devices with the new color iris, or what's now being called the bright ocular iris, implanted in Panama, implanted in Mexico, implanted in Lebanon, among other places. These devices have a long trail of blind eyes behind them with large case series reported in the peer review literature. There has yet to be any reports in the peer review literature of safe implantation of these devices. These are not the same thing. These are put in front of the iris. They are not the therapeutic ones. So, spend enough time talking about that. Who thinks they know what happened here? Anybody want to throw out a guess? This is a phaco burn. This was a phaco burn that melted the iris away. Ouch. Got an artificial iris, did well. Anybody want to guess what's going on here? This is a funny looking slide, isn't it? Odd. Turns out that this is a capsular tension ring, Cioni ring in the capsular bag. Here's the edge of the implant lens haptic. This is all artificial iris, all within the capsular bag. Anybody want to guess what happened to this nice young lady? Anybody want to guess now? There's a zoomed in picture. Okay, I'll zoom out. This is an ICL gone awry. Patient had a post-op pressure spike. Ended up toasting the iris, glaucoma and flecken with cataract, lots of problems. This is what she looks like post-operatively. Zoomed in, happy patient, 2020, no light sensitivity. Briefly, we'll run through one last case. Here's a 53-year-old lady, had cataract surgery for traumatic cataract 30 years ago at the age of 23. -3 +3 refraction gives her 20/25. She's got an IOP of 18 on 4 different meds, iris capture of her optic, UGG syndrome, damaged iris, intermittent bleeding. Here's what she looks like, the slit lamp. If you zoom in a little bit, you see a little bit greater things. And we know what the power of the implant lens is, right? It's a 19.5. We know that because it's actually stamped on the lens. Isn't that kind of cool? We don't see that much anymore. So it makes it easy to figure out what the refractive outcome should be. She's actually got decent endothelium, and here's what her calculations come out to as well, which correlate with what her refraction was and what the implant lens showed us. Do we need the Barrett toric calculator to figure out the astigmatic component? Actually, we don't. We've got a refraction. It's much better. That takes into account the posterior cornea. So I didn't run the Barrett toric calculator on this particular case. We just used the refraction. It's a spherical lens from 30 years ago. Here's the topography. I think that's pretty regular. Some of you might argue that it's not perfectly regular, but I thought it was pretty good for a trauma case. Macular OCT is nice and clean. So we've got some problems. We've got a pupillary capture of the implant, the iris abnormality, synechiae through the positioning hole of the implant, and this rind of capsule. So when we took the patient to the operating room, we zoom in. Again, I just love looking and seeing the implant lens power. It's so convenient. We did a limited vitrectomy, which we've spoken about yesterday. Dissected out the firm haptics of the implant lens. That's what it looks like. Again, it's still 19.5. And then we carved a little bit of that thick rind of capsule so that we'd be able to capture an optic. We made it roughly 6 by 4.5 millimeter aperture. We slide our 3-piece implant lens in, and we're just going to gently capture the optic through that opening, so the round haptics are in the sulcus, and the optic, we're going to retract the capsular to tuck it underneath, and the optic is into burger space. Ideally, we're then able to center on the capsular bag. We use that technique that Ike was showing you to suture the iris, which works really super well, and it's very easy, and it works every single time. Oh, isn't that nice? Except for this time. So instead, we decided to just suture to the capsule. That worked out pretty well. And in fact, every once in a while, you get lucky, and you can find that there's an extra piece of iris hiding somewhere where you didn't expect it. And we were able to suture that to the capsule using the cautery technique, kind of tying everything together in this case. We're able to reshape the pupil and center it upon the implant lens. And though not perfectly round, a pretty happy result with 20/25 J1 uncorrected, pressure of 17 on no meds. Remember, it was 18 before on 4 different meds. So, just as the final tips, always address astigmatism, even if you're doing a reconstruction case. We talked about anterior vitrectomy through the pars plana before, and while the iris doesn't always stretch, sometimes there's a little bit of extra. Nothing wrong with sewing the iris to fibrotic capsule if you can't stretch it all the way, and the cautery is a wonderful technique. So thanks very much, and if you enjoy cool cases like this and you want to go to Disney in February, we'd love to have you. Thank you.
Okay, so this is the last talk for for me in the cataract session, and we were talking about a lot about complex work. And this talk is maybe not always all about clinical work, but also it's just the mentality and the approach in managing these cases. These are my disclosures. This is a view of our city in Mississauga, where I live, which is in the west part of Toronto. These are called the Marilyn Monroe buildings. You can see, I'm not sure why they're called Marilyn Monroe buildings, but that's what they call them. Now, when we have to deal with some of these difficult cases, or when we perhaps are interested in difficult cases, I think the question often is, why do we tackle these cases? And I think it probably varies individual to individual. I always have great respect and envy for the climbers of Mount Everest. Something I wish I could have done or wish I could do would be to climb Mount Everest. And the question, when you ask these climbers, why do they do it? What do they say? They say because it's there. Right, because it's there. And maybe they also say, you know what, because it makes them feel alive. It makes them feel like life, rather than doing the mundane in a daily practice, a daily grind. It's great to be a phacosurgeon, and a cataract surgeon, but to do some of the extraordinary work, or at least to think about it and approach it. And this doesn't have to do with surgery. It could be also diagnosing a difficult condition or a difficult patient as well. So just to give you a peek as well, I have to say I probably have a bit of attention deficit disorder, and I don't like when things are really boring. So this is just a view in my OR. As you know, I do like to teach a lot. I like to share ideas. I like to train residents. So just to show what it's like in my OR. And this is just one of our residents here. It's very nice and calm, right? Cataract surgery is very elegant surgery, right? All right. Do we have the sound actually here? Is the sound playing? No, I don't think the sound's playing. That's too bad. No sound? Oh, I have it plugged in. Let's see if it was one more time. Okay, let me do it. There we go. Okay. So this is our OR. I gotta turn the volume up. Come on. That's one very upset nurse next door. So, of course, this was a very good resident and a patient I knew very well, so don't worry, everything worked out just great. But, sometimes we got to test the system a little bit as well. Now, we all vary in terms of where we are in our surgical experience. Some of us are minimalist. We do what we can. Others are doing a full breadth of complex work. And wherever you fit, our goal is to try to move you from one side to the other. If you're on this side of the curve, let's push you even more. If you're here, let's push you more as well. These are a couple of excited residents with us as well. As we kind of talked a little bit about, I think just to sum up what complex work is, complexity is really simplicity multiplied. It's putting together simple steps, well thought of, planned out well, in a coherent fashion, well executed. And that's really what complexity is, and certainly in the OR. And I can tell you, at least in the OR, I feel this works fairly well. This is, again, I sometimes challenge myself doing cataract surgery and work on my posture here as well. The other thing that, of course, is really important is collaborating. Collaborating is not just bringing us in the room together and putting our ideas together, but it's coming up with ideas and thoughts that you never could come together if you weren't in the same room. So we don't just glue things together. It actually is coming up with new ideas, working together. And it's all about innovation. It's all about challenges, trying new things in a controlled fashion and challenging ourselves, being uncomfortable. And I find the bigger problem is not coming up with ideas. I know there's many students here and residents here as well. You probably have the best ideas of anybody in the room, but you probably don't realize that potential. The biggest challenge we have is indifference and apathy to ideas. Or, you know what, that's not going to work, let's forget it. And of course, then we get deterred and we stop and then we move on to something else. That's probably the biggest challenge of something that we do as innovation, but it means you have to be resilient. You got to be resilient like never before to push your ideas forward in approaching these problems. And do it in a way that's hopefully without ego, because in every profession, in every walks of life, we see that ego can really destroy great ideas and great relationships. And everybody has an ego, first of all, let's admit that. You know, it's important to check it at the door, to recognize it's there, and to put it out of your mind as much as possible. This is, I think, a really good quote, and I think this really applies to what we do here. You know, the most dangerous phrase in the language is, "We've always done it this way." How many times, by the way, the residents here, do you hear your staff tell you this? Why do you do a certain way? Oh, because we've always done it this way. Or because my teacher taught me. Right? What a great line that is. Understand why we do things, whether it's because of evidence, whether it's because of clinical experience or anecdotal experience. Understand why we do things. Why do you have a flow rate that goes from 0 to 55 in linear control in position 2 and 3? You know, why? I mean, have a reason why, and make sure you can define it. And certainly don't be afraid to be different. I mean, I think, you know, you heard one of the greatest surgeons on the planet, Michael Snyder, speaking here, right? Great guy, but he's different. He thinks differently. I mean, you see that. You know, and if he didn't think differently, we wouldn't have the innovations he's brought to the field. And I don't know why Michael thinks differently. It's the way he's wired. You know, I'm not saying he's odd. He's not odd. He just thinks differently, which is great. You know, I think I know why I'm different. You know, I was born in Canada. I was born up north. I'm proud to be Canadian, but you know, being you know, the only brown guy in class was being different. I didn't like it. It was difficult. I mean, look, my mom dressed me up in a suit for my class picture. His mom must have talked to her. And you can see, I mean, I'm up in the top left corner of the picture, right? I'm not with the cool people. I'm way out in the corner. I wasn't hanging out with the cool people. I was different. I knew it. Even if everyone treated me similarly, I was different. But I definitely was a ladies' man. So don't worry. I definitely had this, you know. I'm kidding. This actually was ethnic day for ethnic diversity. You can see, though, we had basically everyone wearing Scottish kilts, and I think this was their Halloween costume. So when we approach these problems, remember, let's identify the problem, question everything, what you've been taught, find a solution, and prepare to fail. And failing is not a problem, but failing to get up after failure is a problem. So get up and continue along here. You know, as cataract surgeons, this is our cat, by the way. This is our cat. Actually, it's a fake cat, but we must remember our technique should be elegant, ergonomic, and efficient. That's what ophthalmologists are. I want to be an orthopedic surgeon until my second year, and what really drew me to ophthalmology was the work we do. Our ORs are our lab, and I love recording and watching videos, and you can ask my family. I'm watching videos all the time, editing videos. When I'm working out, I'm watching videos on my big screen TV. This was when I first started practice with SVHS tapes. I can be very messy at times. This is probably before a meeting. And then now, of course, we've got high-tech, 40 terabyte hard drives recording all our videos. And on my wall here, I have a little picture quote from Muhammad Ali to give me some inspiration. Impossible is nothing. This was a case that perhaps was impossible. This was a case of a young patient who was NLP in one eye, angle closure in that eye, vision was down. She had good vision before, but progressive neovascularization and with a history of Fanconi's anemia and bone marrow transplant at a young age, limbo stem cell deficiency, but still had a good central zone present. And I went back and forth with the corneal surgeons, and they did not want to do anything to her cornea at this point, or a limbal transplant. They said, I take out her cataract. I looked at her UBM, thickened lens capsule. The zonules seemed to be okay. Very small eye, 1.96 millimeter depth or 2 millimeter depth or so, with a short axial length of about 17 millimeters or so. We chose to use a 46 diopter lens, a foldable Zeiss lens here. But our bigger problem here was actually how do we properly visualize here. Again, just to show you 8 millimeter microcornea eye. It's always harder when you're under the microscope than at the slit lamp, and the view was not good at all. So some trypan blue is going to go in. Let's take a look here, and this is where using an endoscope can be very helpful to visualize what's going on there. You see somewhat of a dense cataract there. I wasn't sure whether I was cutting through the anterior capsule, so let me see if I can look. So now we're going to place the endoscope to our main incision. We're going to use our left hand here through a paracentesis to start the rhexis with a microforceps, looking into the eye. So this is yes, not a routine case. I realize that, but I want to just pose it out there that I had never done a case like this, and this was probably about, I don't know how many years ago, maybe 7-8 years ago. I had never done a case like this before, but we prepared really well, read the literature, familiar with our endoscopy, and you see I'm basically doing a rhexis. I'm making sure it's a continuous rhexis. I want to make sure it's 5.5 millimeters, of course, right? And could carry on using an endoscopic view a bit through, and there we got a nice rhexis at the end of the case. Not end of the rhexis, sorry. You can see I've got a good rhexis, curvilinear, with a dense cataract. We'll do phaco here. Hydrodissection. I wasn't sure whether I was going to be under the capsule, so we'll do it under endoscopic visualization. And then we'll continue our phaco, which, and I don't mean to boast, but when you really are comfortable with phaco, you don't need to see what you're doing. I know this sounds kind of funny, but you kind of can tell what's going to happen when your hands go in a certain position and you chop and do certain things, and you have confidence in your fluidics. I've never operated blindfolded, but I'll tell you how we train our fellows shortly. But this is kind of where we kind of use our sense of what to expect. Every time you touch a tissue, you know how it's going to react, and you know that because of your experience and because of your observational skills as well. Side illumination helps, and there we have a plaque. Mike, should I do a posterior rhexis? I knew you probably would say that. Well, we actually didn't in this case. But here I'm doing IA. IA was difficult. I couldn't tell where the cortex was, so I'm doing endoscopic assisted IA, removing that cortex, and then we'll basically put a lens in the eye. I want to make sure it's going into the eye, so we endoscopically deliver it through endoscopic view, and making sure it's in the bag, and that was basically the end of the case. Lots of sutures, of course, as well. So this is how we train our fellows and our residents, right? We blindfold them, we make sure they walk around the room, and once they can walk around the room without hitting anything, I let them operate. So sometimes it takes a few months. I'm kidding everybody. Okay, let's deal with, and by the way, we also have some challenges always as well, like these cases. Again, I have to admit I do get a little bored in the OR, so we have a game I play for new residents that come into the OR. How many clips can I place on their back end without them knowing it? This is my record. I think I got 5 on this guy here. And actually it's amazing, and this is the lesson. This resident was so zeroed in and focused on surgery, he's forgetting everything around him. He's forgetting his proprioception in his ass is basically deficient. And the lesson here is don't have tunnel vision when you work, right? Think about the environment, think about your hand position, think about the microscope, the patient's position, the head, anesthesia, the periorbital region, the cornea, everything that we do here. It's very important to think about these things. This is my typical position in the operating room, falling asleep. I was very upset with the new Alcon machine because they got rid of the footrest, and I was really unhappy by that. Okay, let me show one last case, a case that was the reason why I went into the glaucoma. It's a traumatic dislocated cataract with atonic pupil and a pressure of 50. Yes, this certainly could be managed with a lensectomy or intercap. But when the capsular bag is there, I try to fight for that capsular bag. A little puritomy there, just to set up for the Ahmed valve we're going to put in here. Vitrectomy is going to be important. Anterior infusion, Michael spoke about this yesterday. I think as angiotomy surgeons we should be comfortable with this. There's that lens bouncing around. We'll trim it up there. And then we're going to use something that I really thank my retinal surgeons for, which is scleral depression. So thank you to all the retinal surgeons for teaching me scleral depression. We'll depress with a Q-tip here, bringing the lens up, and then using a microforcep, we'll basically grab the anterior capsule after placing some strategic iris retractors for a reason. We'll levitate and grab the anterior capsule, and this is simultaneous creation of a rhexis as well as anterior levitation, using a couple of forceps to help us to do this. And once we have, that was the hardest part, was basically getting the rhexis started. Now the rhexis is started, I can place iris hooks on the peripheral, on the capsular rhexis edge to now hold the bag. So now I can carry on and continue forward, making a nice rhexis here. I do this case to prove to you don't need femto laser to be a great surgeon, okay? Just to prove that. Now, we have a couple of CTS case capsular segments to place on the bag, placing it into the capsular equator, hold the bag in place with a couple of capsular segments. These are like coat hangers with an iris hook placed upside down. They act as retractors here. A CTR will go in, so we have the bag on lockdown. The rest of the phaco is pretty uneventful. And you've already seen the suturing techniques for zonular devices. And we place the Gore-Tex suture to suture around each segment. Around the segment, tie it down. And then we place an IOL in the capsular bag. So we're not done yet, actually. We have to do the atonic pupil repair. So let's do that. I've already shown you the rest. I'll just fast forward that. Purse string around, tie the suture down. And then finally, we'll place our Ahmed valve present here, suturing it down. We'll use a technique that Mauricio Tarati came and visited with us, and we now adopted this technique. Felix Hill and Mauricio and the gang at APEC that use a scleral tunnel, placing it through there, and then closing up, and that's basically the end of our case. So, yes, I know I don't expect everyone to go out and do this case, but the lesson here is, again, challenging yourself, doing things beyond what's expected, and share. Don't forget to share, and don't forget to teach, which is what the power of the internet and the power of social media is to share ideas, medical ideas, as well as making sure we take care of humanity. Thank you very much.
Opportunity to be here, and it's always so fun to speak in the same section as Ike. And so I'm going to ask you all to do me a favor, because I am laser focused on this presentation. And so if Ike is sneaking up behind me with a bunch of clips, will you please let me know? Just give me like a wave or a shout from the audience. So I'm going to talk about nano-ophthalmos. You've seen a couple of cases already. I do want to acknowledge that there's a couple things that you might see that will be relevant to my disclosures. So what's the big deal about the nano-ophthalmic eyes? Well, we know that there's certainly tight quarters. There's not a lot of space to move around. We know that we have posterior pressure during surgery. The IOL calculations are difficult. There are limited IOL power availabilities. And many of these cases also have zonulopathy. That's something I don't think we've discussed quite as much yet. There are high risks for ciliary effusions or malignant glaucoma. And so for these cases, I always preempt by using mannitol intravenously, 50 cc's of 25% mannitol, 30 to 45 minutes prior to surgery. It reduces the vitreous volume. It also reduces the orbital congestion. Both of those things reduce our posterior pressure. Again, identifying why are we doing these things. I place the patient in reverse Trendelenburg position. This also further reduces orbital congestion and further reduces periorbital venous pressure. All of these things reduce our risk for effusion. I like general anesthesia, and I will put these patients to sleep almost invariably, unless they're elderly. The general anesthesia, inhaled anesthetics give us smooth muscle relaxation, again, reducing central venous pressure and orbital venous pressure. Really important to use general anesthesia with paralysis. If you use an LMA and you're not using paralysis, you're not getting the full beneficial effects, because the paralytics relax the rectus muscle action and they reduce the posterior pressure. Almost makes it a nearly routine case. Here's a video that I'm going to run through, and I think I'll zip through it a little quicker. This is a 19 millimeter eye. You can see the superior iridotomy, which is almost always present in these cases, and it really looks mostly like a fairly routine case, in fact. And the pupil gets smaller and smaller during the case, as is pretty common, but as long as we're staying in the central safe zone, all is well. I always place a capsular tension ring in non-ophthalmic eyes. These eyes have bad zonules so commonly that it's very important to have a ring in place in case there should be subluxation of the lens. Subsequently, makes it infinitely easier to repair. I like to place the rings in manually so that I can feel the tactile sensation and I can know that there's not a catch on the capsular bag. In this place, we're putting in a high-powered SN 6AT implant lens, probably somewhere around 38 or so in this eye, if I remember properly. And as Ike mentioned yesterday, I always like to do an iridozonular hyaloidectomy to create a unicameral eye so that there's a connection between the anterior and posterior chamber. I use a very slow cut rate and I create a nice little opening, and then I turn the vitrector down in the other direction, and we go through the zonules and take a little bit of vitreous in that space as well. And that really is a wonderful help. And this patient ended up 20/40 uncorrected, 20/25 with a different refractive error than you might guess for only a two-line difference. But these implant lenses actually do induce some spherical aberration because of their extra high powers, and in fact it sometimes gives them a better range of focus. I'm going to show you another case which is somewhat similar. I'm going to zip through the straightforward parts. Hydrodissection. And this, you can see that this is a soft lens, so it's a pretty uneventful phaco, right? And it works out pretty well until the capsular bag is aspirated into the phaco handpiece. So the last thing we want to do right now is to take the phaco out. We don't do that. Instead, we reach for OVD, and we're going to reinflate the capsular bag with OVD and repressurize the anterior chamber with OVD. This is not a vitrectomized eye. The vitreous is still in the eye. Now, we're going to use Bob Osher's dry aspiration technique to remove the residual cortical material. And while it might be a little bit tedious, we just use a 27 gauge cannula on a 3 cc syringe, half filled with BSS, and we gently aspirate the soft peripheral cortical material, adding additional OVD as we go. Now, we've got a significant zonular dialysis, but we also have a fairly small eye. Look how big the capsular tension ring is compared to the anterior segment. So this is a type 1G Sioni modified capsular tension ring, and we're just putting a bunch of little bends in the ring to make the ring smaller. It's what I like to call shrinking the ring, and we just adjust the ring size to what we need to do for this particular size eye. We're about halfway there. We'll make another couple of bends around until we get the ring to a more amenable size for us. I won't bother you with each of the little bends, but we'll zip forward a little bit further. Then we place this ring in. You notice that we've got the equatorial capsular material out. There's still some epinuclear material. Ken Rosenthal, I like to quote as having said that we should put in a ring as late as we can, but as soon as we must. And so in this instance, we're just going to thread that ring in, and they'll place the fixation element into the area of the greatest zonular weakness. Remember, this is an eye that still has an intact hyaloid face, amazingly enough, because we've maintained a pressurized anterior chamber the entire time. We're going to retrieve these pre-placed Gore-Tex sutures, and then we simply aspirate the residual material. Now, I do want to show you one thing that's a little bit different. Ike had mentioned that there's only one implant lens available with diopters up to 60. That's actually not true. You don't have to go to a diffractive lens. Human Optics makes a custom version of lens that actually will go up to 60 diopters. This is a 55 diopter lens, and it's a hydrophilic acrylic lens being placed into the capsular bag, and it has that same three-piece design. We're injecting it very slowly because it's a very thick lens, and I don't want it to come out too abruptly in this fairly fragile capsule. It still comes out somewhat abruptly. It's a big lens. And then it really goes in the same way as any other J-shaped haptics might be. We tuck the knot inside the eye, and we hydrate our wound. We remove the OVD from behind the implant and from the anterior chamber as we ordinarily would. And then we're essentially done with the case. And ta-da, ended up with a happy outcome. But there's a couple things that we need to talk about that are relevant for this. Did I forget anything? Maybe, maybe not. So let's talk about it a little bit. First of all, reminding general anesthesia with paralysis is super important. Reverse Trendelenburg, intravenous mannitol, capsular tension ring, iridohyloideo-zonulotomy. Ooh, shoot, did we forget that? What happened in case 2? Well, we actually had a 6-hour zonular dialysis in case 2, so there was already a nice opening there. We didn't need to put one in, right? Always thinking about what's different about every case. But I do agree with Ike that the iridohyloideo-zonulotomy is a really good way to prevent this thing, which might be called malignant glaucoma or aqueous misdirection. Ike doesn't like that aqueous misdirection term, versus choroidal expansion. I agree that the iridozonulohyloideotomy is a wonderful technique and it's very effective. I don't understand how it would be effective in treating choroidal expansion. So I'm not sure that I would go with that hypothesis. I do think it really truly is an aqueous misdirection of some sort. But that's an academic question. The fact is the IHZ works. What about scleral windows? Let's talk about scleral windows for a minute. There are some studies looking at this. 60 eyes, 38% had effusions when there were no scleral windows, 17% had effusions when there were. We actually run closer to the 17% without creating scleral windows, but I don't fault anybody for scleral windows, but do keep in mind that nothing is a free pass, and scleral windows are no different. I do have one patient that I was actually scrubbing on as an assistant to a case during my fellowship, in which a scleral window was performed preventively at the beginning of the case. And as it turns out that during the case, the scleral window opened up, the choroid popped out, and vitreous came out through the eye wall. It didn't end up pretty. So do keep in mind that nothing is a free pass. If you're going to do a scleral window, it might be prudent to do it at the end of the case. Personal choices. I always use atropine post-op. These patients are at risk for effusion, they're at risk for issues and shift. Atropine post-op at least for the first couple of days, ideally for the first week or 2. Power calculations we should talk about for a moment. We talked briefly before about how high-powered IOLs do much better with Barrett 2, Olson, and the Hill RBF. The Hill RBF is actually an artificial intelligence-based big data program, so it doesn't really matter what the divergence is, and it doesn't really matter where all of those measurements are mathematically, because the program is looking for pattern recognition. Now, we all might look at this and we might see different things. We might see a pattern of 2 guys, one of them holding a bale of hay, the other leaning against the wall. Or we might see an elderly gentleman. Different patterns. When we have a computer seeking out the patterns, it doesn't care what the context is. It's only looking for patterns. And the nice thing about the RBF is that it has what's called a boundary model. And in the boundary model, it will tell you whether the data set that it contains is giving you enough information to make an accurate prediction. And if it tells you that it doesn't have enough information, it will say use another formula, use another calculator. That's pretty powerful. Very amazing. rbfcalculator.com. It's available for free. So piggyback IOLs, I think Ike has put this to rest. I actually don't use piggyback IOLs in any instance, especially the non-ophthalmic eyes. There's only one study that shows a case series with good follow-up, but it's only 6 months of follow-up. Usually these problems occur later down the road. Again, there are two different IOLs that are available in ultra-high powers. The Human Optics MC6125, which is a one-piece with J haptics, and the diffractive plate haptic that you saw Ike present with the Zeiss CT Extreme. Thanks very much. Really been a pleasure to be here with you all today.